Good morning, good afternoon, and good evening to speakers and delegates from all around the world. Today, under the aegis of Mumbai Hematology Group, it gives me immense pleasure to introduce Dr. Amit Khurana sir. So, just no other than no introduction is required for such a moderator. So, just a formal introduction. Dr. Amit sir is basically a bone marrow transplant specialist, not only into hematology but also into different conferences. So, sir has done fellowship in clinical hematology. Sir is practicing as a hematologist based at Surat. Sir is in various hematology but from last decade. Sir has fellowship in bone marrow transplant in hematology as well as clinical hematology, hematological and hemato-oncologic patients. So his experience in performing bone marrow aspiration, bone marrow biopsy, and other hematological procedures, autologous and allogenic stem cell transplant. With that, in order to keep the ball rolling, I will request Dr. Amit sir to come to and introduce our.
Thank you, Mr. Somnath. Well, very good morning to all of you, and good afternoon and good evening to all others who are joining from rest part of the world. Today, our guest speaker for the day is no other than Dr. Saikat Datta from Bhopal, and he's going to lecture us on Polatuzumab-based treatment of diffuse large B-cell lymphoma. This webinar, as usual, is brought to you by Mumbai Hematology Group, supported by Roche, Intas, Unipath, Natco, and Lucian Life Sciences, and very well managed by Perfect Square. I thank Team Intas, Roche, Unipath, Natco, and Lucian, Mr. Yash, Mr. Kalpesh, and the team from Perfect Square, Executive Committee of Mumbai Hematology Group. Our chief guest for the day, my friend Dr. Nilesh Vasekar from Nashik. Our guest speaker for the day, Dr. Saikat Datta from Bhopal. All our discussants who are themselves very eminent hematologists as well as hemato-oncologists, and you participants for sparing a Sunday morning, afternoon, or evening from whichever part of the world you logged in. Let me give a flavor of our next weekend activities. Next Saturday, that is 8th of November 2025 from 7 p.m. Indian Standard Time and 7:30 a.m. Central Time, we have Dr. Brad Carl from St. Louis, USA speaking to us on what is new in lymphoma in 2025. And the following day, that is Sunday, 9th of November 2025 from 11:30 a.m. Indian Standard Time and 7 a.m. French Time, we have Dr. Jardin Fabrice from France speaking to us on large B-cell lymphoma, new directions at EHA and ICML meetings. Let me introduce our discussions for the day, and they are well displayed here in alphabetical order. I will pause for a while for you to have a look on all our discussions for the day for very eminent hematologists, hemato-oncologists, as well as medical oncologists all across the country. Some more. So these are our discussions for the day. And now it's a time to introduce our guest speaker for the day. We have with us my friend Dr. Saikat Datta from Bhopal. He was from the same institute, did DM in hematology from NRS Medical College, and it's privileged to welcome Dr. Saikat Datta to all of you and to introduce him. So he is a senior consultant hemato-oncologist and bone marrow transplant physician at Apollo Sage Hospital, Bhopal. And he has about more than 11 years of experience as a clinical hematologist, hemato-oncologist, as well as BMT physician. He completed his DM in clinical hematology from very prestigious Institute of Hematology and Transfusion Medicine, Kolkata, and pursued his advanced bone marrow transplant training at Tata Memorial Hospital, Attract, Mumbai. He has authored 12 international publications and is actively involved in patient care, research, and academic teaching in the field of hematology and transfusion medicine. Today, he is with us and is going to lecture us on polatuzumab-based treatment of diffuse large B-cell lymphoma. But before he does that, let me introduce our special guest and the chief guest for the day, my very best friend, Dr. Nilesh Vasekar from Nashik. I have no words for Dr. Nilesh Vasekar, but it's my duty and a formal duty to introduce Dr. Nilesh Vasekar to all of you. Dr. Nilesh Vasekar is consultant hematologist, Department of Hematology and Bone Marrow Transplant Center at Nashik Hematology Services and Ashoka Medical Hospital, Nashik. It's my privilege to welcome Dr. Nilesh Vasekar and to inaugurate our webinar and give some words of wisdom. Well, thank you so much. I stop over here. Over to you, Dr. Nilesh.
Thank you, Dr. Amit. Thank you for nice introduction. And I would like to thank Dr. M.B. Agrawal sir for giving me this opportunity. Today, all my respected chairpersons, faculty, and dear colleagues and young trainees, I'm going to talk about three gurus who shaped my journey in hematology. It is an honor to reflect upon the influences that have shaped my journey in hematology. When we speak of gurus, we do not simply mean teachers. We refer to those who illuminate a path, who shape our thinking, and who instill values that become the compass of our professional and personal lives. My journey has been guided by three such gurus. My first guru is my father, who laid the foundation of my values long before I entered medicine. He was a person of quiet strength, discipline, and unwavering dignity. He shaped my curiosity of science and encouraged my pursuit of medicine when I was still a child. Life took an unexpected turn when he was diagnosed with CLL, chronic lymphocytic leukemia, that brought me face to face with the world of hematology, not from textbooks, but from lived experience. From him, I learned patience to understand disease as a process, not an event, patience to listen before you act, and patience to walk with patient and not ahead of them. My second guru is none other than Dr. M.B. Agrawal, a name synonymous with hematology in India, a figure we all respectfully recognize as one of the foundational pillars of the field. I first met him while navigating my father's illness. Under his guidance, I witnessed how clinical excellence and human compassion can coexist with grace. His clarity of thoughts, structured reasoning, and commitment to the advancing field have influenced generations of hematologists across India. From him, I learned passion, not just for knowledge, but for continuous improvement. The passion to ask better questions, to challenge the protocols thoughtfully, and passion to build systems, not just treat cases. And my third guru is hematology itself. Hematology is a specialty that demands perseverance. Our patients, their diseases teach us humility, resilience, and precision. Each blood smear, each marrow, each relapse, each remission is a lesson in the complexity and beauty of human biology. The field evolves rapidly and it demands that we evolve with it scientifically, ethically, and empathetically. To the budding hematologist here today, I share this message. Let your passions guide your approach. Medicine is mastered slowly through observation and reflections. Let your passion fuel your learning. Never allow routine to diminish your curiosity. And let perseverance define your journey because hematology rewards those who stay committed to both science and humanity. To summarize, my patience comes from my father, my passion from Dr. MBA, and my perseverance from hematology itself. If today I stand here as a hematologist, it is because of all these three gurus who shaped just not my career, but my character. Thank you.
Thank you, Dr. Nilesh. Wonderful crafted speech. Fantastic words. No words to you. What a beautiful speech you've given. The word guru, what you said was truly amazing. And I think one must learn from you because I have learned from you because you are my guru
No, no.
during the bone marrow transplant fellowship in Singapore. And no doubt your calmness, your generosity has brought you today what you are today. And thank you so much for being our chief guest for the day. And wonderful words, wonderful speech, fantastic crafted speech, and the word gurus, what you brought out, is marvelous. Thank you so much.
Thank you.
And now, Dr. Saikat Datta, the screen is yours. Please go ahead.
Is it visible?
Not yet. Yes, now it's visible. Can you make it in full screen mode?
Uh, can I start, sir?
Please go ahead.
Yeah. At the outset, I would like to thank Dr. Amit sir for my kind introduction. I would thank and oblige to Professor M.B. Agarwal sir for having me here and the whole Mumbai Hematology Group. Today we are discussing polatuzumab-based treatment of DLBCL. So, if you see the journey of a patient of DLBCL after diagnosis, first-line treatment for all patients up till now was R-CHOP therapy. It's a great therapy with 60% of cure rate, but that has also 40% relapse and refractory patient. So they need second line treatment, transplant, or then again third line treatment also. So when RCHOP was compared to CHOP, the 5 years PFS was 54% with RCHOP and 30% with CHOP. So there is great improvement when we added rituximab with CHOP therapy. And till then, for last 20 years, R-CHOP has been the standard of care for first-line treatment of diffuse large B-cell lymphoma. But there are unmet needs. R-CHOP works well in low IPI cases, early disease stage, and GCB phenotype, but not that good in case of high IPI, patient aged more than 60 years, non-GCB phenotype, double hit and double expressor lymphomas. So there has been a continuous trial to improve the outcome of DLBCL. Investigator added enhancing anti-CD20 therapy, addition of targeted therapy in form of rituximab, bortezomib, ibrutinib with R-CHOP. They tried to add chemotherapy like gemcitabine, infusional therapy like DAR-EPOC, and R-CHOP 41. There has also been trial of maintenance therapy, but ultimately all failed. So there is a significant unmet need to improve treatment outcome in DLBCL. In this scenario, one medicine came, polatuzumab, which is an antibody drug conjugate. The antibody attached to the CD79B, and the drug is MMAE, monomethyl auristatin E, that insert into the cell and cause microtubule disruption and apoptosis of the cancer cell. So after 20 years, this new drug came and approved by EMA in 2022, and FDA and CDSK approval got in 2023. So this is the famous and pivotal Polarix trial, after which this polatuzumab along with CHP was approved in first-line DLBCL. This is a randomized trial having more than 800 patients. Patients were having IPI of 2 to 5, 18 to 80 years of age. One group received Pola-R-CHP, 6 cycle, and another group received the standard R-CHOP therapy. So if you see the progression-free survival in this two group, there is a separation of curve. 76% 2-year PFS in case of Pola-R-CHP, which is 70% in case of R-CHOP arm. So there is 6% gain of progression-free survival if we use polatuzumab with CHP. Though it's disappointing to see there is no overall survival advantage in 2-year follow-up. So by cell of origin, if we do the subgroup analysis in this Polarix trial, we see that we don't have much benefit in this GCB group, but in ABC group, there is a separation of this graph. So there is significant improvement of PFS in ABC subgroup of DLBCL when we use polatuzumab upfront. So this is the DLBCL, which are double expressor, like they express BCL2 MYC, but they don't have rearrangement or translocation. So in this double expressor group also, if we use polatuzumab upfront, they mitigate the adverse prognostic implication of this double expression. Patients who have extranodal disease when receive Pola-R-CHP, they have better PFS compared with R-CHOP therapy. Subgroup analysis in case of elderly patient also showed that Pola-R-CHP give better PFS compared with R-CHOP therapy. So this is a 5-year follow-up of Polaric study. Initial follow-up was around 2 years. Now this 5-year follow-up showed that this PFS gain of 6% still maintained when the patient was followed up for 5 years. And patient who went into CR, that CR was maintained at the duration of 5-year follow-up. Though even at 5-year follow-up also, overall survival doesn't differ in these two groups, but numerically there was less death in Pola-R-CHP group. There is less disease progression and less death. Subsequent therapies required 23% fewer in case of Pola-R-CHP received patient. Whatever the subsequent therapy, it may be either systemic chemotherapy, radiotherapy, CAR T-cell, or transplant. Patient who receive Pola-R-CHP required less treatment compared to R-CHOP therapy in their subsequent journey. So when we do the subgroup analysis in every subgroup, double expressor lymphoma, double hit lymphoma, elderly patient, high IPI, bulky disease, all subgroup, when we use Pola-R-CHP in front line, they give good hazard ratio, and they are favorable compared to R-CHOP therapy. There is no special safety concern. Peripheral neuropathy, febrile neutropenia, and cardiac morbidity, those are comparable with both this group, R-CHOP and Pola-R-CHP. So with this, NCCN guideline included this Pola-R-CHP as a therapy in stage 1 to stage 4 disease as upfront therapy. So today, standard of therapy for any DLBCL IPI more than 1 is Pola-R-CHP, which provide better progression-free survival for our patient. Now, DLBCL is a heterogeneous disease with many molecular subtypes. So in our day-to-day clinical practice, it is not we're not able to do the molecular subgrouping for lymphoma, but there are several systems like Polarix trial use lymphogen system, cluster is another system, and dark zone signature another system, which are used in case of DLBCL to re-stratify this disease. So if you see the ABC compare with GCB tumor, DLBCL, which are ABC, have less PFS. That is seen in several trials, and previously there was a trial to improve the outcome of this ABC phenotype by adding rituximab, adding ibrutinib, and adding bortezomib with R-CHOP therapy. But all these were failed. But in this Polarix study, as I already mentioned, when we add Pola with RCHP, this ABC group has better outcome, better survival probability compared to R-CHOP therapy. In Polarix study, they use lymphogen system to subgroup this DLBCL, and they showed that EZB and MCD subtypes, they have favorable outcome when Pola-R-CHP was used. So there is a thing called dark zone signature. Previously, we call it double hit signature. This is the transcriptional subtype. Like dark zone is this area of lymph node, which is germinal center, usually centroblast. And dark zone signature means the lymphoma has very high proliferative index and they have unstable genetics. Dark zone signature containing lymphoma, they have poor prognosis with R-CHOP. And they are usually contained in this GCB group. 22% of GCB tumor have dark zone signature. When they're given Pola-R-CHP, they fare well compared to R-CHOP therapy. But in our day-to-day clinical practice, we are not being able to re-stratify DLBCL such a way. This is still investigational. So if we compare with lymphogen with DLB class stratification system, in lymphogen system, around 40% of DLBCL are non-classified. They cannot classify those tumor with any of this, but this class system, they stratify all the 100% DLBCL in any of these 5 subgroup. And there come a very interesting trial which published this year that Pola-R-CHOP, when they are given in the this Polaris trial population, they showed that this class 5 tumors, they have great advantage by adding Pola. Whereas class 1, class 2, class 3, and class 4, this DLBCL don't have much benefit by adding Pola. So this is the future of DLBCL possibly, that like AML, we will class stratify DLBCL in several group, and group which is having this class 5, possibly we would give Polatuzumab to those patients. But at present, these are not available with us. For class 5, 5-year progression-free survival with Pola CHP is 70%, and with R-CHOP is only 42%. It's a great separation of curve, this class 5 DLBCL patient. So this was the upfront therapy with Polatuzumab. Now we'll come to relapse refractory DLBCL and use of Polatuzumab. This is the GO29365 study design where Polatuzumab was added to BR therapy, and they are compared with BR. So Pola BR versus BR, both arm having 40 patients, and there is an extension cohort of 106 patients. This patient, they were transplant ineligible and they relapsed and stratified BR versus Pola BR. So if you see the result, CR rate was 42% with Pola BR arm, where only 70% CR achieved with BR therapy. So with adding of BR, there is a great advantage in case of relapse refractory DLBCL patient for whom we are not going for a CAR T cell therapy or high-dose chemotherapy or transplant. For this patient, there is PFS of 9.2 months in Pola BR arm, whereas in BR arm, it's only 3.7 months. So great PFS advantage adding Polatuzumab with bendamustine rituximab. Median overall survival is more than a year with Pola BR group, and with BR, it's only 4.7 months. And if we see by subgroup analysis, the patient who received up to 2 lines of therapy, who are non-refractory to their previous line of therapy, they achieve 94% overall response and 91% CR. So great percentage of CR achieved with Pola BR who are non-refractory to their previous patient. And if we see the median PFS, it's around 1 year for patients who are non-refractory to their previous therapy. And here we can also see the survival advantage also. The median overall survival for non-refractory patient was 32 months, and non-refractory to previous therapy, the median overall survival was not reached. So we have to take it with a pinch of salt because 9 patients of this trial received CAR T therapy, 1 patient autologous, and 3 patients also received allogenic transplant. When patients condition improved, they were headed for the further therapy after this Pola BR. So 10 patients of this trial, around 25%, they are still living and they are still maintaining their CR after 2 years. So it's a great achievement. Like previous upfront therapy with Polatuzumab, we see there is no survival advantage shown after 5 years. But when we are using second line of therapy, there is PFS advantage, great CR and CR rate, and also survival advantage with patient. And these CR are not very short-lived. CR we are getting up to 2 year, 3 year also in this cohort. Another study who used Polatuzumab in a relapsed refractory DLBCL patient, where patients are not eligible for transplant. This patient received Polatuzumab R-GemOx, and they compared with R-GemOx. This is a randomized phase 3 study. And this study also showed that overall survival benefit when Polatuzumab with R-GemOx. So adding Polatuzumab causes survival benefit. There was 19.5-month median overall survival with Pola Argimox. With Argimox, it is only 12.5 months. Added ratio is excellent, 0.6. So 40% reduction is risk of death with Pola Argimox in this study. And this study showed that both ABC and GCB subtypes worked well with Pola Argimox. This PolarGo study showed that with our Polar Gemox, CR rate was around 40%, which is double of the CR rate of Gemox only. And the overall response rate was around 52%, with Gemox only it is around 25%. So CR rates was also double, and overall response was also double when we are adding Polatuzumab with Argemox. This is a smart trial. This is also a trial which conducted in case of patients who are not transplant eligible or eligible for CAR-T. This is 1B/2 trial. It's a single arm trial uh, who use glofitamab with polatuzumab in relapsed refractory DLBCL. Patient received obinutuzumab 7 days before the cycle 1 to decrease the chance of CRS. Glofitamab is a bispecific therapy, like CD3, CD20 bispecific. So this was added with polatuzumab, and glofitamab used in a step-up manner. They started from 2.5 milligram the first cycle day 1, and then it's ultimately increased to 30 milligram. So with this therapy, like this therapy is yet not approved in US, but it's approved by EMA. With this therapy, we can see the overall response was around 57% and CR rate of 18%. For DLBCL, the overall response is 57%. If you see the PMBCL population, the CR rate was very high, 100%. Duration of response with this in the study, 2-year median EFS was 51.9%, and duration of CR, like 2-year event-free survival, was 63%, which is great actually. PFS 2-year is 41% in the study, and overall survival is 54% in 2-year. Great result actually. CRS rate was 43% in this study, but most were grade 1 and 2. Tocilizumab required for 34% patients. Steroid requirement was in 14% patient. ICU admission required for 5% patient in this trial. Peripheral neuropathy rate was comparable with other trial, 26%. Now, which I described those 2 studies, those were for transplant non-eligible patient, but this study with Pola RIs, this is for transplant eligible patient. We are using this for salvage therapy. This trial like use Polar RIs for salvage therapy, and they showed 92% response with 55% CR rate as a salvage therapy, which is a very good outcome for salvage therapy. The overall outcome, like for this patient, if we go into a remission for 55% patient, we can further adding for CAR-T therapy, or we can do autologous and or allogenic transplant for this patient. So adding polatuzumab in upfront therapy, adding polatuzumab with relapse therapy, all improved patient outcome. For upfront therapy, it improved PFS by 6%. By using polatuzumab in post-remission relapse therapy, they actually improve survival for our DLBCL patient, and it's a great salvage therapy when we add polatuzumab and I, so that more and more patient can be taken to transplant or for CAR-T therapy. So with this, I will conclude my talk. Thank you very much.
Thank you, Dr. Saikat. Wonderful talk, very crisp talk, and I think you covered almost everything. All the regimens, starting from the transplant eligible to non-eligible, what regimens to be given, and what is the durability of giving polatuzumab upfront and in relapse setting. So with that, we can start with our question answer session. Dr. Saikat, if you can please unshare your screen once.
Yes.
Thank you. Yes, Dr. Krishnan Kannan, your question, please.
Good morning. Thank you very much for an excellent revision of Polatuzumab. I just have got about two or three questions. The first question is the dark zone signature subgroup is synonymous with double hit or just a subtype of double hit? And the fifth count, the C5, the five groups, the last group which showed an excellent response, do they belong to the dark zone signature?
No, sir. Yes, drug zone signature is the double hit or triple hit part, but that C5 they are actually like C1 and C5 is ABC. So by Polarix trial, we know that this drug will work better with ABC trial, but not all ABC. Like C1 also ABC, C5 is also ABC. They work better in C5 ABC group, and these are not like double hit or triple hit lymphomas. They are not included in C1 or C5.
The other question I had was the primary mediastinal B-cell lymphoma. Any studies for upfront therapy of polatuzumab in PMBCL, primary mediastinal B-cell lymphoma?
Not approved yet, so they have not included in this trial.
Okay. Then the other question I had was for elderly, high risk lymphomas. We normally give mini chop, R mini chop. So can we combine Pola with R mini chop, although they may not be published? And is there anything you should observe for any extra toxicity when you use polatuzumab?
So I think it would be a great choice. Like our minichub is not a very good therapy, but we don't have option. Like someone at the age of 70, 75 with come to with stage 4 DLBCL, we use our minichub, but their durability is low, and in many cases where we have signature like MIC or BCL2, they relapse. So adding it upfront would be good if it's a ABC kind of tumor, but in case of GCB, I don't think so that it will give much benefit.
And for young patients with double hit lymphoma, we give DAR epoch. So you think Pola will replace it or still continue to use the DAR epoch for young double hit lymphoma?
So in case of double hit lymphoma, I still use DAR epoch who are like younger in age. But for older patient, Pola or CHP is a reasonable option. I think for them, we don't be able to give this DAR epoch. So young patients, still I use DAR epoch.
Thank you. Thanks for the clarification, all the practical problems.
Thank
Thank
you,
you.
sir.
Thank you, Dr. Karan. There is one question from Dr. Darshana Rane. What is your choice of CNS directed therapy when you use Pola?
I didn't get it.
What is your choice of CNS directed therapy when you're using Pola based regimen?
So for CNS directed therapy, we give CNS prophylaxis only for like very high CNS IPI of 4 or someone having double hit or triple hit lymphoma. For other patient, I don't give CNS prophylaxis. And for CNS prophylaxis, in my practice, I don't give IT, methotrexate or triple IT. I usually give 2 dose of high dose methotrexate 3 gram meter square, and that is not also intercalated after end of whatever therapy you are using RCHOP or Polar CHV. After completing that, I give those methotrexate, and this is systemic methotrexate, not intrathecal.
Thank you. Another question I have is Dr. Gopinathan.
Good morning, sir. Thanks for that excellent update. While dealing with young patients, now the recent NCCN guidelines says for bulky mesenteric disease we can do polatuzumab. So if we have a patient with GCB DLBCL and they come to you with bulky mesenteric disease, will we still consider polatuzumab for their induction, or we just go ahead with a straightforward therapy?
The problem with Polarix trial is it is not powered to comment upon that we can't give Pola and GCB. It's a subgroup analysis, it's a post hoc analysis. So, like I will say, I don't have the answer still now that we can't use Pola in case of GCB. We don't have that answer yet. We need to restratify the patient beforehand, doing trial like GCB versus non-GCB, and giving Pola to both of them. But this trial don't have power to say that we can't use. So we can use, obviously, even in case of GCB.
Yeah. And the second question is, what would be our strategy for a patient of DLBCL with upfront CNS involvement? If they
So,
have a
so it's not a primary CNS lymphoma.
no, sir,
It's a
systemic. Yeah,
it's
if
it's
they
a
have,
it's a
it's a systemic disease, but upfront they have an CNS lesion or CSF involvement. So what would be your approach to those kind of patients?
So in case of CNS disease secondary, like we have DLBCL and a CNS disease, if we can't give, if you give cytarabine and high dose methotrexate, that will be great. So Archa-Vardap therapy alternatively, or you can give high dose methotrexate after completing Archa therapy. Initially, you can manage with some IT chemotherapy tests, like patient is having CNS symptoms, or we can complete the 6 cycle of Archa and then give 2 to 4 cycle of high dose methotrexate. Doing intercalation is a bit difficult. Like I have initially started with intercalation with high dose methotrexate, but actually my Archop therapy got delayed.
And a role of consolidative autologous transplant in double hit lymphomas, sir?
At present, even autologous or allogenic transplant, they don't have, like, they don't improve the outcome. What data we have right now.
So any trial or any anecdotal reports that you use Polatuzumab in post-transplant lymphoproliferative disorder, PTLDs?
No, I don't know.
No.
As it up.
Sure, sure. Thank you, sir. Thank you so much. Thanks.
Thank you, Dr. Gopinathan. I'd like to add a comment on what Dr. Gopinathan just asked about the secondary CNS involvement in the case of diffuse large B-cell lymphoma. There was a beautiful talk just about 1 month back by an expert from USA. And what he said was, if a patient has got a secondary CNS lymphoma, the whole direction is now on the CNS part rather than the systemic part. So, but the main risk area is now your brain, not the systemic. So whatever you're going to use for the systemic type of thing is going to take care of your systemic for brain type is going to take care of your systemic part also. So the whole thing now goes towards the CNS directed therapy when you have a secondary CNS lymphoma, and automatically the systemic part is going to take over by the CNS directed therapy. So the whole concern is to go for the high dose methotrexate and high dose atropine based therapy, and eventually the systemic part is also taken care of. So I think what Dr. Gopinathan just asked basically is, when you have a secondary CNS lymphoma, is important to treat the CNS part rather than to treat the systemic part, because once a CNS is the biggest risk and the is involved in the treatment of DLBCL. So what he said was basically to go for a high dose methotrexate and high dose atropine based regimen immediately, not to take part in any systemic based therapy, because your methotrexate and cytarabine upfront is going to take care of your systemic part also. So the whole thing goes towards the direction of CNS guided therapy when you have a secondary CNS involvement. And being DLBCL being a parenchymatous uh, uh, growth, not the dural based growth, it's questionable basically whether the intrathecal chemotherapy is going to help or not. So parenchymatous, definitely a high dose methotrexate, high dose atropine based therapy. That was the message which was given by the expert from USA.
So do you
Thank you.
use hypersevered MA for this patient?
You can go for, because the whole brunt is to go for methotrexate and cytarabine. So the 1B part of hypersevere, that is MA part, is the way forward, because you are going giving high dose methotrexate and you are giving high dose cytarabine, because the whole thing from systemic, it changes to the CNS part now. So you must target the CNS, leave behind the systemic part. So when you are proven that the patient has got a CNS involvement in case of DLBCL. Well,
Yeah.
so
Great input, sir. Thank you.
Thank you. Thank you, sir.
So there is one question which has come from Dr. Darshana Rane again. Will you call cavernous and spheroid sinus involvement uh, in oropharyngeal, nasopharyngeal lymphoma as a CNS involvement?
So with standard IPI, like CNS IPI, it is not like CNS high risk otherwise. But initially, when we started our CNS prophylaxis, like any paraspinal mass, any nasopharyngeal involvement, we used to give intrathecal methotrexate, but nowadays we don't give for those patients.
Thank you. Another question from Dr. Nasrin Akhtar. This is related to primary CNS lymphoma, which is DLBCL type. What is your recommendation about consolidating the patient who is 51 years of age after remission with 5 cycles of RMPV? So what is the consolidation after RMPV 5 cycles in primary CNS lymphoma, DLBCL type?
So I will go for autologous transplant with using 5-TEPA.
Okay, thank you. Another question is from Dr. Bhuvesh Varnath Gauri. There is a tendency to see an increased number of atypical infections and admissions in Western patients where polar RCHP has been used upfront. Is there any practice for a more cautious approach, especially with certain patients in India, for example, in cases of like who has got past TB infections?
So no, I don't give any antitubercular prophylaxis for my patient. And for polar CHP also, I give standard prophylaxis, no antibiotic prophylaxis, PCP prophylaxis, and for herpes zoster prophylaxis, I give treatment. Otherwise, I don't give anything special.
Thank you. Another question is regarding your polaric study, which you mentioned.
Yeah.
It's a beautiful update. One is very clear that your Polaris has got some benefit in patients who are more than 60 years of age, who have got IPI score between 3 to 5, who are double expressor, who are triple expressor, non-double hit, non-triple hit, and ABC subtype. So if you are going to use in this subgroup of patients, in your real world experience, did you find any of the patient who has not responded when you are dealing with such patients or you're selecting such patients based on polaric study?
With my personal experience, the few patients I have given polatuzumab all responded well in frontline and also in relapse setting.
All the patients JCV versus as well as non-JCV both.
Yes, yes. I don't say I have a huge experience with polatuzumab. I have used in only a few patients.
Thank you. And when there's one question related to toxicity of polatuzumab, regarding the Indian patient and the Asian patient versus the Western patients, are there any difference of toxicity?
So actually not much difference. Like they had Asian subgroup also in politics trial, not much difference. Like they have neuropathy comparable with R-CHOP therapy. But obviously like in our country, infection is like different. If someone is having like febrile neutropenia, many times they landed upon with MRD, multiple drug resistant organism. We see in our practical case, even with R-CHOP also, with febrile neutropenia. Like in India, the organism like we are see Klebsiella nowadays who are meropenem resistant, when they are not working with Klebsiella. So that is difficult for a patient who are older age and we are using Pola RCHP and they are having febrile neutropenia. For my patient, I give growth factor for all the patient at day 4 who are using with Pola RCHP.
Thank you. And are there any biomarkers or the clinical features which can guide you that, yes, this patient must receive polar RCHP?
So as of now, any patient like we have only Hans algorithm and we can do fish for our DLBCL patient. I don't know like NGS it is freely available or not. We are like restratify our DLBCL patient according to molecular signature. It's not possible in India right now. So I give polar CHP like I offer like if they are financial affordable to all ABC subtype.
Thank you. And regarding the older patients, which I think Dr. Kannan has already mentioned, with very query can you use with polar R mini chop therapy?
Yes, I think it's a
Yes.
reasonable choice.
And suppose can you use with polar R CHP to all older patients with some dose reductions? If you want to use polar R CHP older patients,
See,
because
like we can do it. Like sometimes I have started with full dose of R-CHOP. They like admitted with an episode of febrile neutropenia. I have made it to mini CHOP. Like I've started with CHOP, then like went into mini CHOP. This happened for many elderly patient, like more than 70 years age. But I will say that mini CHOP is not a good treatment. They relapses very frequently.
Thank you. And you said about the relapse refractory setting, a famous regimen that is Pola BR. That is one regimen. Another
Yeah,
regimen
that
sort
we can
uh,
use. Pola BR and Pola RGMOX we can use. Like even in elderly, Pola BR is better than I think Pola RGMOX. So there is no comparable trial, but cytopenia would be less with Pola BR.
and about Pola Obino glofitamab, there was a second thing what you showed, but that was a smart trial.
Yes.
Any trial which is adding with lenalidomide, Pola plus len, because with
So
bispecifics you already shown with len.
so so we have like Viper trial, which have many drug like venetoclax. We have in that lenalidomide also. So in this Viper trial, they now added Polatuzumab to Viper, and they like have seen that they can use it. Like, and the result is not out yet, but there is no new safety concern with Pola added to Viper. So with ibrutinib, lane, venetoclax, obinutuzumab, and prednisolone plus Pola, we can use it with a combination.
Thank you. And in relapse refractory setting, you got now multiple options in Indian market also. You have got CAR-T, you have got
Yeah.
bispecific antibodies. Now Pola is in the midway. So if a patient relapses, what will be your algorithm? Where to fit Pola, where to fit bispecifics, and where to fit CAR-T, where to fit autologous stem cell transplant, and where to fit allogeneic stem cell transplant in a flow chart.
So like relapse within 1 year or refractory patient, they won't do well with your chemotherapy, high dose chemotherapy, and autologous stem cell transplant. So if you are primary refractory or relapsing within a year, possibly CAR-T is the best treatment if the patient is affordable. So it will be best. Otherwise, like patient is transplant eligible, it's a late relapse, we can easily go into salvage therapy and autologous transplant. In salvage therapy, you can include polatuzumab. We have now data. Then autologous stem cell transplant. Allogenic transplant, like I'm not very sure, like they are relapsing after CAR-T bispecific, possibly at that time. Like we have many options. Then we went to like we can also sometimes do like we give CAR-T, then we are doing allogenic transplant to further consolidate those patients.
And before CAR-T, any role of salvaging the patient with Pola?
Yes.
And the
Before CAR-T, if you decrease the disease burden, it will be good for patient. There will be less CRS, the result will be better. So obviously we can like and this Pola BR trial, they had a total 40 patient with Pola BR, and among them 9 patient went to CAR T-cell therapy. So it's a good therapy to reduce the disease burden.
but the BR will not cause a problem with the CAR-T generation.
Yeah, that's a problem. Like we can collect CAR T after 1 cycle or so. Then like after you have controlled the initial disease, we collect the T cell and give the further 2 or 3 cycle of therapy. You can also give polar GMOX for those patient or polar rice if like if you are going for a CAR T cell therapy and patient is like ECOG 1 or 2, obviously we can give RICE therapy also, polar RICE therapy also.
So there are two most famous regimens which is coming up before CAR-T now. A patient relapsing within first 12 months. One is your Pola RIs, which you already mentioned, and another is Glofit GMOX, which is
Yes.
most thing. So between
Yes.
these two things, Glofit GMOX versus Pola RIs before CAR-T, what would be the best favorable, Pola RIs or to go for Glofit GMOX?
See, Glofit GMOX would be better. Like if we have glofitamab, but they are, I don't know, they are now giving it in compassionate basis or not. It's a costly therapy. Obviously, polar RIs would be cheaper.
So 2 cycles followed by transplant, followed by
Yes.
CAR-T. One question has come regarding Pola maintenance. Any role of Pola maintenance?
As of now, I don't have any data.
Well, thank you. So Any other questions anybody has? Well, so there are no more questions, no more raising signs, and no more questions from the chat box. Well, thank you so much, Dr. Saikat, for the wonderful overview of polatuzumab-based treatment for DLBCL. And you covered almost everything from frontline therapy to relapse therapy, and what to be used, what not to be used, when to use in the flow chart, where to fit before CAR-T and before autologous stem cell transplant, salvage therapy. That was beautiful and wonderful. So thank you so much. And
Thank
one
you,
question
sir. I
just,
also enjoyed the discussion.
before I close, one question has just come that how do you manage polatuzumab-based neuropathy? How do you
Like,
how do you treat polatuzumab-based neuropathy, and how much time does it take for the neuropathy to recover?
so it's like happen in case of R-CHOP therapy, the neuropathy and Pola RCHP, it's same, like it's 20-30%. So usually we don't reduce the dose if the neuropathy is grade 1 or grade 2. If it is not very severe painful neuropathy, we also consult with a neurologist and we give amitriptyline, nortriptyline, this kind of medicine, also pregabalin. So this kind of medicine usually help in grade 1, grade 2 neuropathy. If in grade 3, we can reduce the dose.
How much it usually takes time for neuropathy to resolve? Does it remain or it goes away after some period?
So if you are continuing polatuzumab, it will be there, but symptomatic relief will happen with this kind of medications.
So within, I think, 6 months, it should resolve, I think.
Yes,
After
gradually.
therapy,
Gradually, after stopping the therapy, they will resolve.
next 6 to 12 months.
Yes.
Yes. So thank you so much, Dr. Saikat, and very special thanks to Dr. Nilesh for being our chief guest for the day. And now I hand over to Mr. Somnath Banerjee for the final vote of thanks. Is there? Well, so he's not there. So fine. Thank you, Dr. Saikat, once again, Dr. Nilesh, and all our delegates as well as discussants over here to participate, and meet you next week, Saturday, Sunday, with another beautiful webinars. Thank you so much.
Thank you, sir. Thank you. Good.